Hopefully you can all hear me. What I'm wanting to do with you today is to share with you a bit about what the course is about, here offer you the opportunity to ask questions with regards to the course, and hopefully inspire you with being able to connect with the concept of working with addictions, working with the deeper elements of psychological disturbance. Welcome to this preview. Welcome. Hopefully, I'm going to be understanding a little bit of what you want to get out of and potentially coming on the course as we go through. Now, it hopefully goes without saying, when we're looking at addictions, we're looking at pain, psychological pain, we are looking at presenting issues that are challenging. And those of you who know us know we don't pull our punches when we're talking about things. We talk about the reality of it for our clients, the reality of it for us, the therapists, and we're also talking about how to protect ourselves within that perspective. Addictive behaviours, well, of course, we're going to be mentioning and talking about substance abuse, understanding what it is, understanding what can drive it, what promotes it, and obviously understanding how people can move away from that. We're also talking about sexual addiction. With sexual addiction, it's really interesting that people who are sex addicts, like to have multiple partners, tends to be with sexual addictions. It's the sexual experience is not necessarily a gratifying experience. They feel compelled to do this. And one of the very interesting things about it, it's a behaviour. Substances are drugs. But when they've looked neurologically at people who are sex addicts, so addicted to pornography, addicted to sex, addicted to those types of behaviours, neurologically they show exactly the same changes that you would be expecting to see in somebody who is a cocaine addict, which is a genuine addiction. There are neurochemical, neurological changes, and good old dopamine coming into effect, which is driving the compulsion to have lots of sex, whether it's through pornography or whatever. With any addiction and other pain-related issues, there is always the element of codependency, and we will be exploring codependency within this context, because often when you're working with an addict of some description, you may well be working with their partner or partners. There's an element that we have there. We are looking at emotional pain. We bring in the concept of bereavement and loss with regard to this, and we bring in several layers of that. There's the typical bereavement, losing a partner, a parent, or somebody like that. But also we have to recognize that bereavement and loss come in many shapes and forms. You may be presenting with somebody who has lost their job, for example. The process of loss that they're experiencing is parallel to the process of bereavement, of loss that somebody is experiencing with the loss of a loved one. An area that quite often we don't look at is a loss of a pet. Here, certainly in the UK, we are obsessed with our pets. They're called fur babies and all of that. When somebody undergoes the loss of a pet, it's just as devastating for people as the loss of a fellow human being. We have that. There's also other layers that we need to be aware of within regard to that, not just the loss of something living, loss of an identity. When I was in my early career, I was working with people who were coming to see me because their children, they were parents, their children had grown up and left home, and they had lost, and they were experiencing a bereavement response at their loss of parenthood. Even though they're still a parent, but the children are no longer at home, there is a loss there. They had a loss of identity of being a mother or a father with regards to that. Loss of a limb, or a loss through a mastectomy or testicle removal. You've got the loss of something that defines you in your gender concept, your concept of your gender. There's also the challenge with pregnancy loss as well, especially early term pregnancy loss. People don't seem to take that. Oh, it's a shame, but you can have another one. And for the parent and the mother and the father, or the other parent that might be there, it's as painful a loss as the loss of a full-term baby or a human being. We need to be aware of those. Loss of fertility as well with infertile couples. An area that responds very well to therapy, and it is a challenge I'm working with, I'm working with terminal illness and people experiencing end of life, or the family members going through and sharing that end of life journey with their loved one. Therapy, and with regard to that, we will be exploring. And also looking at things like ADD and ADHD, not just in children, but also in adults. A lot of people with neurodivergent people being diagnosed with ADD or ADHD in later life. And yes, I know there are huge controversies over what ADD is, in what ADHD is, and the concepts there. Interesting debates, but for us as therapists, the important thing is we are working with people who are finding their state of mind and their worldview challenging. We can help with regard to that. And yes, we're looking at depression and anxiety. We're going to be exploring, again, how to deal with deeper levels of depression, going into depressive disorders, a major depressive disorder as well, and extremely high levels of anxiety, which perhaps we don't normally connect with as therapists and with standard trainings. And we bring in the concept of cultural competency here as well, with regard to the world we live in. COVID changed everything, lockdown changed everything, MCO orders changed everything for us, and we went online, just as we are now. One of the reasons we're talking like this is because come the pandemic, we had to move online to do the teaching, and then the world opens up. And likewise with therapy, the world opened up when we went online. And so an understanding of culture, an understanding of how culture can affect the various presenting issues that we are exploring. In the IP course, we do explore culture and identity in much greater detail. But on this course, we've got the cultural elements and cultural competency that helps to deal with the elements that we are speaking about on this particular course. With regards to what we're teaching on our courses, our advanced courses, before we teach solution-focused therapy, and it's an added extra that we put in to all our advanced level courses. We're very used to working as therapists with looking at problems and problem resolution. Solution-focused therapy brings in a very interesting concept where we don't really we acknowledge there's a problem, but we don't really talk about it. We focus on solutions. It came from the work of Steve DeShazer and his teams in Palo Alto in America with regard to family therapy, and then it grew into one-to-one therapy. And Steve DeShazer and his team were also trained Ericksonian hypnotherapists as well. And from that perspective, the ABPP course, we have a module about solution-focused hypnotherapy, how to apply the solution-focused model within the hypnotherapy approach. And also, let's keep it positive. For several reasons. One, it's good to have a positive focus anyway when you're learning. And two, with regard to the approaches that we will be teaching and talking about, positive psychology, solution-focused approaches can be really, really effective with them. We're bringing that element in with regards to that. We've got a whole host of approaches that we're going to be exploring as well. Some advanced dissociative techniques, and they're quite advanced dissociative techniques, dipping into Ericksonian hypnosis with apposition of opposites. It's an approach to placing a problem and a solution next to each other and creating a mental equilibrium within the brain. You've got the mind-body dissociation, very powerful technique, where I call it it's a psychological decapitation. I don't ever say that to my clients, but it's a really useful technique where you've got some physical sensation that's holding you back. People going through end of life with a lot of pain, people presenting with deep levels of depression where they've got somatization and they're feeling it heavily in their body, people with high levels of anxiety. What this technique does is it guides the client into hypnosis, deepens the mind and the body, and then when that client is in a deep trance, we further deepen the body, but we wake the mind up. You've got a very alert mind, but a completely hypnotized body, which is a really nice way of helping people to experience relief from intractable pain within the body, pain that perhaps pharmacology can't manage, to help people have a escape from the deep sense of depression, the deep sense of anxiety they may be experiencing. We teach it for some, we use it for several reasons. One, we can use it with people with depression, high levels of anxiety, to gain a clearer, more objective process within therapy. And with people in intractable pain and end of life, it gives them that relief to perhaps interact with their loved ones, to be able to watch television, read, or something like that. We've got a technique called the coach, which is a nice technique where the client in 101 different situations gets to coach themselves in therapy to make the change they're wanting to create. And also a nice variation on the apposition of opposites, the polarity dissociation, which is an alert technique that allows people again to look at a problem, look at the solution, and create an equilibrium and balance in the mind. We're also looking at the past. We're taking our regression approaches, and we are teaching quite an advanced technique called the advanced pseudo-regressive therapy, where we combine pseudo-orientation in time or hallucinated age progression with regression. Really useful approach that basically goes around the concept, of gaining hindsight to have foresight. We're guiding people into a situation where they get insight from the future that they can then bring into the past to guide them through coping with a negative past event. That element's there, and anyone knows me knows I love my inner child work, and we have an inner child approach for codependency that we'll be using with regard to addictions or any form of codependency that's in there. We're also exploring paradoxical interventions. Paradox is quite an in-your-face intervention. It needs to be done judicially, but when you do use it, it's very, very powerful. And basically with paradox, therapy is taking the client in a direction contrary to their expectations of a therapist. For example, you might have a client who's saying, I feel terrible. Now, generally, as therapists, we would explore and help to lift them up. With paradox, what you do is you agree with them. Yeah, you probably are the worst person I've ever seen, and I don't know how you're going to be able to get better. There's a very good reason for doing this. It's not being horrible to them. It's matching and working with a negative expectancy in their mind. It's a very careful mirror, pace and lead that we work with. And that simplifies it. There are a lot of approaches. Where you have really resistant clients, the paradoxical approaches are really, really superb. And we're also going to be looking at introducing and bringing in quantum psychology, which is Eastern philosophies, Western physics and Western psychology all brought together within the concept of quantum physics. And that's a very fascinating area. It does work with the concept of quantum realities. We do know now, there is a lot of evidence to show that the quantum elements that we're experiencing are very real. But putting that aside, they are superb therapy techniques for helping reframe and create reframes, very powerful reframes for people. And as we are moving into a more spiritually world that we're living in at the moment, it fits very nicely with a lot of expectations of people. And quantum approaches are really good, especially with things like addictions, because it's very metaphorical at one level. And what you're able to do is work metaphorically on some very challenging experiences an addicted person has, and work through them without having to overtly confront certain elements. I personally, as a therapy approach, I love it. Very, very useful. I use it with people I work with addictions of all types. We use it with the trauma clients that I work with. Very, very passionate on that one. That gives you kind of idea of what we're doing within this particular course. And the course has been gaining recognition in areas around the world with regards to what we're the quality of the people we're producing. And we just want to highlight a collaboration that we have. Had a collaboration a little while now. I was down in Malaysia before Christmas, and dog wanting in before Christmas, and I got an opportunity to visit the people at Green Wings. Basically, they have said that people who graduate from the ABPP course can have the opportunity for paid placements. They're based in Kuala Lumpur, and already the people in the UK and not in Southeast Asia are probably going to be any use to me. Yes, it will be, because the offer is for face-to-face or virtual therapy with regards to that. We've also got a collaboration that's only just started to come to reality, very recent, with a rehabilitation organisation in Thailand. And again, they are offering placements for our graduates, quite nice placements. They will be on site for a few months, I think, and for people who want to do that, go and live in Thailand and helping people who are having problems with addiction. Details, we've still got that coming up, but just to show you, with Green Wings, they are very, very important. They are pioneers, as it says there, on holistic mental health care. They work with addictions of all types, certainly work with panic disorder and anxiety, ADHD, work with people with bipolar disorder, schizophrenia, and they also, the nature of each of these types of issues does also impact on relationships. They also offer marriage therapy within that. It's a really lovely, important collaboration. As I say, we're building up collaboration. We've got people in other areas of the world as well who are showing interest in working with our graduates from this course. With regard to that, it is an opportunity. Other opportunities are going to be opening up itself. Not sure if you're totally aware, but the ABPP course itself begins on the 2nd of October. It's our next intake for the course, and Risk has already introduced herself in the chat. For those of you interested who aren't hypnotherapists but want to learn some hypnotherapy, our next hypnotherapy course begins on the 11th of October in 2025. It seems very odd saying that. I'm just getting used to it. And now we're in September, heading towards 2026. But just to put into context, you've got 4 live weekends with the ABPP course, and they are interactive, they are practical, and very practical in that respect. You've got a series of 1-hour midweek lectures that you will be able to, that you can attend. All the live sessions, as I'm sure those of you who've worked with us before realise, they're all recorded. 80% attendance, live attendance is what we're looking for. But the recorded sessions, if you're finding it challenging to appear at the midweek lectures, you will have opportunity to watch the videos of that. You'll also have the opportunity to review the sessions from the weekends with regards to access to the videos. As I say to everyone, the videos will only be made available to people on that particular course. They're not shared with any other course, because some of the nature of what we talk about is private, bit confidential. We aren't taking it outside of your particular cohort or group. Examination wise, we've got continuous practical assessments, so we're observing during the practical courses, practical sessions rather, and there is an online MCQ, which is an open book MCQ that allows you to basically have a look and just make sure that you understand the ins and outs of what we've been talking about and teaching you. It's not an onerous examination. And those of you going for the AppDip, if you want, what you have there is a series, you have to present a series of case reports using integrative approaches, and then there is a viva on your case reports with regards to that, fitting in with a lot of the advanced training systems within the university system that we are aligning with. Now's your chance to ask any questions about this. It's challenging. I'm not going to beat around the bush. We are talking about end of life. We are talking about dying. We do talk honestly about it. We're talking about addiction and the reality of addiction and what can happen to people with that. But at the same time, we are talking about how to help people either feel more comfortable with the end-of-life procedure, certainly helping people to overcome all sorts of addictions, irrespective of what they might be, and also irrespective of how people out there perceive them. We go in unconditional positive regard, working with people who are going through a challenge. Yes, somebody may be addicted to pornography, they may be addicted to sex. Ours is not to judge. Ours is to help that person understand perhaps where that addiction has come from, but also very importantly, they're with us because they want to overcome it, how they can overcome that. And do you know what? I've always found working with people with those challenging presenting issues opens up a new concept, a new perspective of the world in which I live, and helps me as a human not to be as judgmental as I perhaps was many years ago before I stepped into this particular world moment. I'm going to stop the share so I can see everyone. That's better. What brings you guys to perhaps working with addiction? Anybody want to share perspective? One of the reasons I moved into working with addiction was my background in psychopharmacology, which is where I originally cut my teeth in my original career. I was working with the drugs called the benzodiazepines, the Valiums and Libriums of this world. And I'm very proud to say that the research group I was working with, we were the first to prove that they were addictive. Roche products hated us because all of a sudden the tablets that people were giving out or doctors were giving out like sweets, or okay, go and take a Librium and take some Valium, suddenly proved to be quite highly addictive. I got an interest in that. And one of the reasons I got interested in being a therapist was because I recognized that drugs help. Drugs, often with the benzos, sticking plasters, take the drug away, the problem is still there. But because of the nature of addiction, I then got very interested in addiction, and that brought me in. And also, as a trauma therapist, a lot of people with trauma have very strong addictions to cope with the trauma. My routine was through that routine, my interest anyway, plus my experience with trauma clients. Anyone would like to share what's bringing them to do this? Lavanya, what brings you? I know, you see, you got your camera on.
So I'm not too sure. Like I think I'm stuck in a dilemma whether I'm taking this course for a wrong reason, because I do want to, I mean, consciously, I do want to help people who, have addiction. But at the same time, I feel like maybe I'm taking it because I have family members who are addicts as well. Yeah, I know at the end of the course, I'm very well aware that, most probably they might not come to me for help, or I might not be able to help them. But yeah, I'm just thinking, is there an expectation, and will there be a disappointment at the end of the day? Yeah, like I said, am I doing this for the right reason? I'm not too sure.
One thing I will say, if you do have family members who are addicts, and I discovered I had family members who are addicts, it gives you a greater insight and an understanding into their journey with substances. But also, I found it gave me an insight when working with my clients who are addicts. There was a perspective that I got that perhaps I wouldn't have had if I didn't have family members who are addicts, which doesn't mean to say that I was any less effective as a therapist. It was just the insightful element that comes in.
Right.
And also, one of the things we find with our client base is that they'll come to us for something straightforward to begin with. And once we've successfully helped them overcome that, they'll then come with the big thing, which can be an addiction or a trauma or something along those particular lines. And, with the state of the world as it is, I'm not going to go down any political journeying there, but people are coping with substances, coping with behaviours, coping with food, alcohol, all those addictions that are out there. How many of you have connected with young people and their addiction to these things? Very powerful. And again, they've shown and demonstrated that people who are addicted to this, addicted to doom scrolling, addicted to all of that, show exactly the same brain changes that cocaine addicts have. So-called psychological addictions have a neurochemical basis to it. And I'm now further understanding that. The neurology of what is happening as well is very strong. And also, let's be blunt as well, as a trauma therapist, I do work with people in abusive relationships. And there is an addiction, and I'm putting that into quotes, but there is an addiction along the same lines that I've just been talking about that bonds the trauma survivor with the abuser, then underpins the whole thing of why you can't just tell someone who's being abused, leave them. It's not as easy as just leaving. Oh, someone was doing that to me. They're addicted. They have an addiction. And we need to be in a position to be able to help those people with regards to that. And I certainly, over the years, have found the approaches that we teach on this course and that we've brought into this course very useful with helping with that. Anyone else like to share?
Hi, Peter. I'm Kohila here.
Hi.
I'm sorry I
Hi,
have a
Tahila.
faulty camera.
That's all right. I can
Okay.
see your photo.
Yes. I have a question here. I've been getting a lot of people who have been inquiring about addiction for their loved ones. But the person who is actually has the situation, they are going through that. They don't come forward. Many cases, that's how it is. How do you tackle that? Because the loved ones are very concerned. We even had, a meeting with them because you're able to come on the camera and so on. But then when it comes to the therapy sessions, they are not that motivated. This has been a situation constantly. How do you tackle that?
You have to, basically, the client the addict has to want to quit. There's a huge amount of fear around quitting because if they're addicted to a substance, push them into withdrawal. It can be a very fearful experience for them. We can work with them to help them motivate. You've got with addiction, you've got pre-contemplation, contemplation, change, maintenance, relapse, and all of that. And we'll talk about that you see that with the smokers that we see. But with the contemplation phase, which is when I think you're probably the people, they're the loved ones bringing their family member to you, they will be either in pre-contemplation or contemplation. We can work without forcing them, but we can do work with regard to helping them gain insight into the most appropriate direction for them. Now, I would want to say everyone quit your addictions. Isn't going to happen. I'm an ex-addict myself, and I say that because I used to smoke, and smoking is an addiction. Thankfully, I've never had an addiction to anything else. But plonk me in a group when I was a smoker, and it's many, many decades since I last smoked, but put me in a group with people telling me I should quit. I know it's bad for me, but I won't do it because I'm not really seeing the benefit to myself. The benefit, I enjoy it. Look, let's get this right. Addicts become addicts because they enjoy what it is that they're addicted to begin with. Somebody shoots up with heroin. It's an opioid. It numbs you down emotionally. Pain will numb you down. Okay, you'll end up throwing up and doing all sorts of nasty things, but just so that you know, heroin suppresses the distaste centers in the brain. You don't feel disgust. So it's helping people in that situation. All we can do is help them to reflect and see the options that are open, but they have to want to do that.
Okay, noted. Thank you.
We cannot, unfortunately, force them into change. This is where a lot of rehabs go wrong, or not go wrong. The challenge that a lot of rehab places have when addicts are given the choice, prison or rehab, and they'll go into rehab, they'll go through rehab, they come out the other side. Once they're out, met the conditions of the court, then they're back on the drugs. A lot of the problems that rehabs anyway have is relapse after leaving, and that's where therapists like us come in and can help prevent the relapse. And Amy says, hello, I have a question. Is it true and related that trauma can cause addiction? For example, a person who was traumatized with sexual abuse during their childhood turns out to be sexual addict or having certain mental issues that related to sexual abuse. Yes, sexual trauma at a young age, sexual trauma as an adult as well, with sexual assault and rape, they can certainly trigger addictions of all types and issues of all types. Somebody who was sexually abused as a child, for example, may well end up overeating, becoming addicted to food, because A, eating food gives them pleasure, B, they put on weight, which then is unconsciously perceived as a protection against the inner core being abused. They've also got the fact that unconsciously, if they're putting on weight, they may not be considered as attractive to a potential, erroneous by the way, but considered not as attractive to a potential abuser. Again, another defense mechanism. You can also find that an abuse survivor, and again, this is quite a global perspective, it's much more complex than this, but an abuse survivor may well end up being sexually quite promiscuous, having a sex addiction, because at a very young age, they were taught that affection comes from having sex, even though they might not have felt it was any pleasant experience. And so as dopamine reward system kicks in and says, if I have sex, I'm going to get affection. And the more that becomes entrenched, remember with sexual trauma, with abusers will say nice things, will really boost that person's sense of self, which feeds the addiction You've got that element that comes in, becomes a nasty cycle. You might find sexually that people get addicted to masochistic activities because, again, equating pain to love and affection. There's a very simple answer to a very complex element here. Got to remember, some people enjoy promiscuous sexual activity because they enjoy it. No real reason to have a problem with that at all. And some people enjoy masochism. That's what they enjoy. And if it's not a problem for them, they won't come and see us anyway. Very simply, elements like sexual trauma in the past, sexual issues, rape. People who've survived rape may again use addictions like overdrinking, drug addictions in order to cope with the distress that they're feeling within themselves. They become addicted, and with treatment of that type of addiction, you do need to deal with the underlying issues, because if you take away the thing that is damagingly helping them, they've got a coping strategy, it's maladaptive, but it's helping them cope. If you take that away, they're just going to bring something else in to cope, perhaps even worse, until they're ready to deal with the underlying issues. That's where a bit of a problem starts to lie in with coming with that. You can also see an element that we don't often talk about, but addiction to plastic surgery as well. People who are abused emotionally or sexually as a young person and being told, you're so ugly, you're lucky that I want you. That message it's used by abusers to control, it's coercive control. But that can then layer a dissatisfaction with the body dysmorphic elements come in. And that's where they decide to start looking at changing themselves. Look at people, for example, public eye like Michael Jackson and what happened to him with regard to his upbringing, which was not the nicest from everything he said and the family have said before. And he was using plastic surgery to change himself because he was unhappy. And then the addiction to that comes in. And a lot about self-esteem, self-value, self-identity comes into the mix here. Yes, things that happen to us in childhood don't always have to, but they can create addictions, behavioural, chemical, whatever, in adulthood. And unfortunately, social media on these things, again, we're told you must look like this to be successful. If you don't, you're not success. Therefore, I have to go and get my face altered, my skin peeled. I need to be really thin, so I'm going to take lots of stimulant drugs that stop me from eating. I worry about the whole thing with Ozempic and everything else. Now that those prices are shooting up, will people go back to some of the amphetamine-based stimulants that suppress hunger? But that's a debate, a whole debate on its own right. But again, you've got the element here with regard to the likes of Ozempic and so on. It's early days. Will we see a dependency coming through on that? Ozempic isn't, and Wegovy and all the others, they aren't physiologically addictive. But I think the mindsets, as I've said before, I cannot be looking good if I don't have my Ozempic. There's an area that I think a couple more years and we're going to see some big problems coming in with that. Take care, everyone.